All right. Welcome everybody to our webinar. First, I want to make sure to mention that this is a webinar, so you will not be able to unmute and you will not be able to turn on your video. You are able to communicate with others here in the chat box, and we also have a Q&A box that you can utilize to ask any questions and make sure that they don't get lost in the chat during the presentation. You are here at our webinar on integrating peers in harm reduction teams and opioid treatment programs, and I am so excited about this. We do have a few housekeeping slides that I need to go over first. We are the South-Southwest Mental Health Technology Transfer Center, and I do need to make an acknowledgement that we are funded by SAMHSA, and I'm going to leave this up on the screen for just a moment for you. All right, and we also have a code of conduct. We haven't actually had to utilize this in any way so far, and I hope that we can continue that streak. We are dedicated to providing events where everyone, regardless of gender identity and expression, sexual orientation, disabilities, neurodiversity, physical appearance, body size, ethnicity, nationality, race, age, religion, and any other intersectional identities feels welcome. Essentially, please be kind. And with that, our MHGTC network does have a affirming, respectful, and recovery-oriented language policy, and I'm going to leave this up here for a moment as well. And the last of our housekeeping items, we have made every attempt to make today's presentation secure. If we need to end the presentation unexpectedly, we will follow up using your registration information. And like I said before, you're not able to unmute or turn your video on. That is intentional, as this is a webinar, but we would love for you to interact in the chat box. If you have a question, please utilize the Q&A box so that we can make sure that your question does not get lost in the stream of chat. And with that, I'm going to turn it over to our amazing presenter, Brent who has been so gracious in giving us his time today.
Thank you, Jesse. As Jesse said, my name is Brent Currently, I am the State Peer Support Specialist for the SOR Grant. Work with the Office of Behavioral Health, part of Louisiana Department of Health. I'm based in Baton Rouge at corporate headquarters, although for the last 2 years, I have been sitting in my dining room, which is where I'm speaking to you from today. I just wanted to give you a little bit of a brief background about, our bios are a big part of our stories as peers. And before we jump into how and why we chose to embed peers in opioid treatment programs and with our harm reduction teams, I think it's useful to just have a little bit of info. My parents were missionaries in Hong Kong, so I was born there and I lived there until I was 17 when I went back to the States for my senior year of high school and college, and then I moved back to Hong Kong. So I'm pretty used to being an outsider, and that has been really useful. I got used to meeting people every year and saying goodbye to people every year, and it trained me to be open and meet people where they are, because my grade school had 45 nationalities and my high school had 50 or more on any given year. And that was a really great training ground for me. I was an athlete and an honor student and all that good stuff because I was trying to prove that I was worth something. And when my ankle got destroyed in a training accident, I found myself with a lot of time. And I immediately learned to fill that with alcohol and other useful substances. Of course, if you also have mental health challenges like I do, it's not necessarily the best treatment for these things. So about 10 years ago now, I managed to find my way into recovery. And a couple of years after that, I was hunting for something to do that was useful and allowed me to give things back. A friend of mine said, "Have you ever thought about peer support?" I hadn't even heard of it. I was living in Austin at the time. I got online, I was looking up peer support training and trying to calculate how long it would take me to save the money for that training. And the man who took me to my very first recovery meeting called me on the phone from Baton Rouge and said, "Have you ever thought about peer support training?" Which I took to be a sign. So in 2015, I moved back to Baton Rouge, went to peer support training, and ended up working at the treatment center where he was the executive director for 2.5 years. And that was where I was headhunted to come and work with the STR grant. So the STR grant was the state targeted response to the opioid crisis. And it was the first time that Louisiana had been involved in the business of medication-assisted treatment. We'd been an abstinence-only state up until that point. And that's where this kind of kicks off. Our initial design for STR, it was quite a small program. We have 10 opioid treatment programs around the state. And we have 10 what are known as local governing entities. The state's divided up into 10 human services districts, and they're semi-autonomous. They get their budget from the Department of Health, but they make a lot of their own decisions and drive their own process on a local basis, which is, has positives and negatives. And one thing we discovered when we started with STR, our initial design was that there was a peer support specialist at each of those local governing entities that we call LGEs. You know how state government is, we love our acronyms. And we had 10 resource coordinators, one at each of the opioid treatment facilities. And the goal was that they would work very closely as two halves of the same team and pass people back and forth as appropriate. Unfortunately, the stigma that has, so often been a barrier to treatment, particularly with MAT, was pretty deeply embedded. And a couple of the agencies we encountered told us flat out things like, "We don't believe in MAT," as if it was the Easter Bunny or something, and it was a choice whether or not you believed in the efficacy of medication in opioid treatment. So for our second year, because we'd encountered this unexpected barrier where they would just not refer to opioid treatment providers, we decided to embed some peers in OTPs. So this was not a grand plan. I didn't have a beautiful vision of how this was going to work out. This was literally a response to a barrier that we'd encountered, and we thought, all right, we'll put some peers in the OTPs, and that'll at least cover us off with SAMHSA so that we can report data and say that, yeah, we did have recovery supports in place. What we didn't realize was quite how powerful this was going to be. This was one of those happy accidents where, I was trying to close a loop, and what I got out of it was massively more. What the state got out of it, what our team got out of it was far more valuable and important than we had dared to anticipate. So initially we had peers in 2 opioid treatment providers in very different regions. One was in the New Orleans area, which is, it was massively busy every single day. The clinic sees 500-600 people every morning. We rapidly increased capacity for STR. We were up to 90, and then we were up to 110 STR based individuals that were being funded by the grant. And so the peer was in, an all action place. Meanwhile, we had a second peer out in Monroe, which is much more regional, much more rural area. And they had people driving in from considerable distances to reach them. What happened was surprising and gratifying. So I'll talk first about the peer at the Monroe treatment facility. She had about 30 STR clients that she was tasked to try and approach and get together with. the word of mouth, standing in line waiting to be dosed in the morning, meant that within a couple of weeks, she was seeing almost the entire clinic clientele on a regular basis. She had something like 90 people that she was encountering at least weekly and sometimes daily. What we saw from that was a reduction in positive UAs, a more rapid progression through their stages of treatment, a deeper engagement with the full suite of recovery services, a connection with their local governing entity, with their human services district to receive physical health care, mental health care, access to supports on childcare, housing, all kinds of other things. So it rapidly became an opportunity to help us provide wraparound services. The plan for this presentation today, I was going to be co-presenting with a gentleman named John Landry, who was our peer at the OTP in the New Orleans region. John and I came up together in the sense that my first training as a peer training facilitator was when he came to peer training. And shortly after he graduated and we decided to put peers in the OTPs, he was my first thought. It was a little bit of a tough sell. He'd been a 9-to-5 guy his entire life until he had encountered the challenges that allowed him to enter recovery. It's a tough sell to tell someone, I would really like you to get up at 3:30 in the morning and be at work by 4:15 so that you can meet people coming to get their methadone dose for the day. John, unfortunately, passed away last December during a quite routine surgery, very unexpectedly. So I'm presenting this in his memory because he reminded me how much of what peer support is about is personal. I used to get calls from him regularly. Brent, I don't feel like I'm getting anything done. Just walking around talking to people. I'm not getting anywhere. I said, John, that's what you're there for. Don't worry, you're earning your money. This will come. He was bored, so he did things like he went out into the parking lot and picked up cigarette butts and trash and just said good morning to everybody. Within a week or two, some of the individuals coming to receive services were joining him in picking up trash and shaming anyone who threw a cigarette butt on the ground. And before he knew it, he had relationships with a whole bunch of other people. The value that created was that they saw him as one of them, because of course he was, and they started to see him on a regular basis. These are some of the things that we didn't really anticipate. He discovered a lot of the reasons that people were having difficulty making all of their appointments, which is a real problem. If you're required to attend 6 days a week, if you miss, it starts looking bad. Positive urinalysis, how committed to this are you, all that kind of stuff. One of the big challenges was transport. The opioid treatment facility is a mile from the nearest bus stop. And that's about the only way to get there. If you don't have your own vehicle, or if your vehicle breaks down, or if your kid gets sick, it's hard for you to appear at an appointment. So he started working with the Medicare transit people. He started working with the counselors to explain what was going on. This link in the continuum of care really transformed people's experience of treatment. What really surprised us was by the end of the first quarter, where we had peers embedded, the STR clients who were receiving treatment for free, we were concerned, I wasn't, but a lot of people were concerned that, well, they won't be really committed because they're not paying for it. They were actually progressing through the treatment phases faster than self-pay clients. They were returning far fewer positive UAs. They were engaged with the counseling staff on a more regular basis and on a deeper level. And that was all because we were able to build a relationship with them at a really ground level. So this stopgap measure to try and allow us to fulfill our obligations to SAMHSA became a key part of our planning for the second year of STR and then moving forward. So the State Targeted Response Grant was purely about providing people who would qualify for medically assisted treatment with the opportunity to receive that when they couldn't afford it on their own. After STR ended and we started working on, it actually overlapped with the SOR Grant, the State Opioid Response Grant. We continued with the model of having peers and OTPs because we'd seen how successfully it had worked. What was really interesting was our initial targeting for the number of people that we were hoping to reach with peer support was, I believe, 1,590 over the 2 years of the STR grant. We ended up more than doubling that. I think the final tally was more than 3,400 encounters that were documented. So on top of that, of course, you have hundreds and hundreds and hundreds of unofficial encounters when you're not just sitting there chatting one-to-one. It might just be an interaction in a parking lot. And while I was 100% convinced of the efficacy of a peer support model in treatment and in any kind of recovery support, that really gave us the proof that peer support is a powerful tool and a really vital piece of the continuum of care when we're talking about a clinical setting. Because there was some skepticism, what value can they add? Are they going to try and be cut-rate counselors? And so, you know, it takes a little while to convince a new population that a peer is there for a very specific set of reasons. They're there to add to the treatment cycle, not to replace anyone. They have no agenda about taking over a little theater of your operation. The goal is to enhance every other aspect of that. That taught me as well that as much as we need a specific set of targets and a specific job description and a list of things that we need to see happen during the life of the grant while you're employed under that guise, it's really, really important that we allow the individual peer to design and drive their own response within that framework. You know, individuals have different approaches and different views on how peer support can be successful, and the individuals they serve have different needs and different requirements, and allowing them a fair amount of freedom within that framework has proven to be extremely valuable for us. As LSOR has continued into 2.0, the LSOR grant's design was to increase capacity of provision of medically assisted treatment around the state. As I said, we're limited by law in Louisiana to having 10 opioid treatment providers, and there's one in each of the local governing entities. But that leaves people in rural settings. They can be 2.5 hours away from their nearest opioid treatment provider. And that's just untenable. They can't possibly do 5 hours worth of driving every day if they even have a vehicle and have a full-time job and manage childcare and all of the other things that go into what we hope is a successful entry into recovery. So LSOR was designed for us, its main purpose was to increase capacity. And so we started using office-based opioid treatment to provide things besides methadone. And so we needed to expand our peer support so that they could also work with those clients around the state. Meanwhile, at the LGEs, we're using peers to encounter people who may not yet be aware that there is a program where they can receive medically assisted treatment, or who aren't suitable for that or aren't interested in that. And what we've gradually done over time is mesh these people. So the SOR Grant uses what are known as crisis mobile teams. They have a nurse, mental health practitioner, and a peer all on the same team so that they can respond to someone who may or may not be in crisis, or who has just recovered from an overdose, or any number of things. And they're there to be a link to send them in the direction they need to go, as well as to work with them directly and provide recovery support. So gradually over time, we're expanding our network of peers. One of the exciting things that we're doing with the 2.0 version of the state opioid response is we're piloting a couple of 24/7 opioid treatment providers. We don't have one that is a full 24/7 model yet, but they're greatly expanded. They are 7 days a week. Some of them are open. I believe the highest number now is about 108 hours a week. So in places like New Orleans and some of the other cities, it allows people to dose at a time that's much more convenient for them at the end of the day after they've gotten their children, or very early in the morning because they have just completed their work as a member of the service community. New Orleans has a lot of late night entertainment and restaurants and all that kind of thing. So people get off work at 2, 3 o'clock in the morning by the time they finish cleaning. Making them come back again at 4:30 and wait around to be dosed is not necessarily helpful. So that model has been very exciting. Another thing we're using peers for within the OTPs, and we're piloting this as well. Nevada pioneered using what they affectionately refer to as Narcan vending machines. They actually provide a lot more than just Narcan, but it's a really interesting model. You get a vending machine, you design it for your needs. They provide wound care kits, feminine hygiene products, safe sex materials, all kinds of things. You can model it based on your community's needs. And it does not require the individual who's using it to be a client of the opioid treatment facility. In Shreveport, where we're pioneering this for Louisiana, they're members of the local harm reduction community. Shreveport's done a really exciting thing where they have anyone who carries the card that identifies them as a user of the local harm reduction team, the police will not arrest them for drug paraphernalia because they understand that these people are engaged in recovery support services. Harm reduction is another way we really want to bring people into the initial phase of recovery. We've learned nationally and certainly locally that any kind of non-judgmental interaction that we can have with an individual raises our prospects of getting them connected with a little bit more care further down the line. You can build a level of trust with individuals when you treat them as people and not as problems. That has surprising results. So we have also chosen to use peers loosely affiliated with harm reduction teams. We have to dance around a little bit because of SAMHSA guidelines and because of state laws and local law enforcement provisions. And we're not doing anything outside the rules, but we keep that connection fairly at arm's length so it doesn't look like, we don't want to create the wrong impression. But by having a peer that can respond quickly, we're able to move people into a level of care where they're comfortable on a much more rapid basis. So this is gradually ramping up. All of this is bringing us to the next phase. By September, the end of September, the state will have 5 regional recovery hubs set up throughout the state. Indiana has a wonderful model on this. We are creating ourselves a heat map of every recovery support service that we can find and identify throughout the state. Recovery community organizations, treatment providers, drop-in centers, anything that falls under the umbrella of recovery support, we want a map for. The people who will be running the regional recovery hubs are tasked with the job of creating this resource guide. And we're going to have an interactive map where you can type in your zip code and find out whoever is available in your region to provide those supports. The regional recovery hubs are going to each be staffed with between 5 and 7 peer support specialists. They're going to look almost like the living room model, but it won't be strictly mental health or strictly substance use. It's open to anyone. It's a drop-in center where you can hang out on the couch and drink coffee and use the computer to send email. And there will be peers for you to talk to. The peers will also conduct group sessions and one-to-one mentoring and serve as a hub where they can connect you with all the services in that region. So that's going to be really exciting because we will then connect those peers with the peers working at the local governing entities, with the peers working at the opioid treatment providers, with the harm reduction teams, and anyone else. So gradually, my plan for world domination is coming together. We're creating a spider web of services all the way through. We really, really want to be able to have a warm handoff from wherever you start to wherever you end up in this process and maintain that. The 24/7 model is a little slow to get off the ground. It's difficult to staff. You know, there are challenges around this, but over time, we're going to work on building that model up a little bit further throughout the state. Transport is, of course, always a challenge. Louisiana is heavily rural. Outside the Southeast, like the Baton Rouge, New Orleans corridor, you can be a long way away from any kind of medically assisted treatment provision. And that can be a real challenge. So the harm reduction teams that are currently in operation, we have 5 of those. They're both static and mobile, as in they have a physical space where people can go and interact with them, and they are also out in the community on a regular basis. So that has shown us as we build those encounters and as they get to know the people that they're serving, we're gradually seeing an increase in the number of individuals who are choosing to enter recovery in a more traditional sense, as in they're looking to start treatment or they're looking to reduce use. They're looking to manage things. So it's a really, it's early days for that. COVID really, like everywhere, cost us a lot of time in the sense that a lot of things had to go virtual. Unfortunately, we've seen that reflected in the numbers. Our overdoses are way up this year, and it's going to be worse as we get more data. So that's been a real challenge, and everyone is hugely grateful that we're allowed to be back out in the field again. And it's been tough. I know every peer I know has lost people that they work with. It's been hard on the team. We now have, SOR is a much bigger animal than STR was. We have 27 separate subcontractors under this grant. So we have peers in all kinds of places working on that, which is both a plus and a minus. It's hard to keep track of all of the moving parts. So one thing we do is we meet monthly on the phone just to decompress and share best practice and successes and challenges. And that's been really important. One of the frustrations of my job is I feel like I push paper instead of encountering people. And so the people I need to focus my encounters on are the peers who are actually working on the sharp end and building them up and making sure they have the resources that they need so that we can continue this. We're also in the process of rolling out Medicaid reimbursable services for peer support throughout the state. So that's going to give us another opportunity to bring in a whole different crew of people working both for managed care organizations and for local governing entities and small recovery providers who will be able to bill for service rather than having to fundraise or get grant money to pay for peers. This is going to make a big difference for us. And the last piece that we're working on right now is something I've wanted to do since the first day of STR, which is one of my big regrets that we haven't been able to pull this off yet, but we are looking to get peers embedded at emergency departments throughout the state. It has been a frustration of mine that we haven't yet achieved that. We now have one in the state. We're way behind some of the other places, and that's an exciting piece of being part of the Region 6 network, because some of the other states have wonderful stuff for us to model and copy off of. We will shamelessly crib your successful approaches, I promise. I am not interested in reinventing the wheel. I just want to be able to serve that population. So I guess the wrap up and the takeaway from this is never know where you're going to find your success. Our initial goal of putting peers in opioid treatment providers was we got a gap in service because people don't play nicely with each other. Throw a peer over there. And we were a little more hopeful than that, but honestly, that was, this was like, we must fill this gap, so we will put a couple of peers in, and it turned out way more successful than we could possibly have hoped for. And as a result, it's a part of our design for anything going forward is, let's get peers in if you're having trouble retaining clientele, if you're having trouble with individuals not making their appointments, if you're having trouble with people returning positive UA screens, get a peer, start encountering it, find out, dig down. We all know, our opioid treatment providers, I think the counselors can see 75 people a week. That's their caseload. And it's really hard for them to dig deep when they have to see, 15, 20, 30 people a morning. So that's something a peer can really be valuable at. So, the power of peer support and backing up even a really strictly clinical, very by the book, heavily regulated service like an opioid treatment provider. I know some people think peers are kind of loosey-goosey and we just float around and chat with people. That's partially true, but that's partially the beauty of the model. It's just proven to be an essential part of the continuum of care. And I'm really looking forward to seeing how our regional recovery hubs will feed into this. I'm really looking forward to being able to drive this model forward as LSOR 3.0 is coming online. We believe that the state opioid response will have a Mark III coming out this fall. They haven't announced it yet, but we have reason to believe that will be in the cards. And so this will be part of the process going forward. So that's my little TED Talk today. Thank you for attending. I really appreciate the opportunity to share what's happening in Louisiana with you guys. And I've really enjoyed hearing what's happening around the region. So I will open it up for questions.
Thank you so much, Brent. We do have some questions here. And we actually have quite a few good ones.
Oh, no.
One of the first ones that I'd love to have you answer is, can you share about what the conversation looks like in Louisiana regarding harm reduction for harm reduction's sake, without an expectation of eventual abstinence, in addition to harm reduction as a step towards abstinence?
Yeah, so this is always, like I said, a couple of years ago, I literally had a senior clinical staff look me in the eye and say, I do not believe in MAT. There's really no good answer to that beyond, okay. And harm reduction is the same way. This is a big nationally. Why are we giving drug addicts needles? Well, we're not under terms of the SAMHSA grant. We can't hand out needles. Those are separate harm reduction teams that are self-funded. Just enabling them. My big take on harm reduction teams is my success rate in working with dead people is 0. Harm reduction is valuable for the sake of harm reduction. Full stop. I have no expectation that you are going to immediately snap to attention and run off to your nearest detox and do that. My goal is to enable people to stay as healthy as possible, to enable people to not get HIV or Hep C and possibly pass that on to a partner. Our harm reduction teams under SOR are also designed to screen people for Hep C and HIV and then get them treatment so that we can keep them healthy as long as possible. What we are seeing anecdotally is that people are choosing to engage in some form of recovery, whether that's just a moderation of use or whatever. But there isn't an underlying agenda. The goal is not to push you straight into treatment. The goal is to keep you healthy and engage with you and meet you where you're at. It took me a long time from the time I knew that I had a really serious substance use problem for me to be ready. I would say it was a solid 4 or 5 years from the day I was like, this is probably going to kill me, until the day I went, I'm done. So I'm all about harm reduction. The work that our harm reduction teams do is amazing. And so, if it helps people to choose a different pathway that works for them, awesome. In the interim, I want you healthy.
Thank you so much. We have another question here asking, who would you suggest folks talk to who are interested in developing an RCO, or recovery community organization, in Louisiana?
That's a toughie. You know what? I would really suggest you go nationally. Opioid Response Network does some great stuff around RCOs, even if you're not focusing on an opioid response model. Trying to think who else we have talked to. SAMHSA has some really good stuff on their website. But ask around in your local region as well. Mental Health Association of Greater Baton Rouge, which just changed their name. I can't remember, literally yesterday, and I can't remember what they changed their name to. They also keep track of recovery community organizations. This is one of the things about what we're doing with the regional recovery hubs. We don't have a great handle at state office on where they are, who they are, what they're doing. And that's one of the reasons we're trying to develop this map, so that we can help them out and bring them into a network and you know, provide support as indicated.
Well, that leads perfectly into the next question. How do I get more information about the recovery hubs that are getting started, and how are the different organizations they're connected with coordinating? More formal, like MOUs, or informal? They also mentioned loving your spiderweb analogy.
Telling you, we're taking over the world just a little bit at a time. The regional recovery hubs, we've tasked one entity with setting up all 5, purely because we want to have continuity of service and an ability to scale this up. And so doing that, those 5 recovery hubs are going to be throughout the state. They're going to be in, let me get this right, Shreveport, Baton Rouge, New Orleans, Hammond, trying to think who my last one is, Imperial Calcasieu, so Lake Charles. What we're doing is we are IATing, so interagency transfer money from LDH, from the Department of Health, to those local governing entities that serve those regions, and they are going to monitor the setup and execute contracts. But there will be like a single contract for all 5. Everybody does their own sort of bits and pieces around their contracts, but they will be contracting directly with a single entity who will run all 5.
Well, thank you. Do you have a specific peer training for harm reduction? And if you do, is it different than other peer trainings?
We don't yet, and we need to. The same as Louisiana has a very rigorous initial peer support training. We use the RI International model, which is 76 class hours over 10 days with a practical final and a written final. And that's a really solid baseline training. But as we put peers in emergency departments, we want to have a specific training for that. As we put peers on harm reduction teams, we want to have a specific training for that over and above your initial training. We're really happy with our basic training, but we really want to have like a specialization training for a couple of different areas. And that's something the state is looking at actively right now and is trying to design right now. So hopefully by the fall, we will have like another suite of extra trainings on top of that. We're also looking at trainings for people who work in correctional facilities.
That's wonderful to hear. We also have another one here asking, oh, we've got even more questions as you're answering them. This one is asking, have the peers providing services in these programs struggled at all to implement harm reduction or oriented services? And if so, how has that been navigated?
Not quite sure. I mean, it's always a struggle. You're always looking for new ways to, especially something new like this. You know, when we first set up the peers and the OTPs, I mean, John must have called me 20 times to say, I'm not earning my money. All I do is wander around and talk to people. It was a really slow burn for him. It took him weeks to have like a full-on sit-down, face-to-face encounter with somebody. You've got to explain what a peer is. You've got to prove your bona fides and that I'm not here to convince you to go to treatment. You know, you have to build that relationship. I try to impress on the people that are working on the various aspects of the grant that there is not a model for this. You're designing your model as you go. I mean, here's your monitoring forms, and this is kind of what we want you to get out of this. But you know, beyond a few initial things that are common to all peer support, it's a real, you've got to kind of make it up as you go along. You know, a lot of this stuff we're building the plane while we're in the air, and there is no landing gear yet, but we'll get there. You know, and that's kind of the approach we're taking. So that's a lot of my role, is to suggest approaches that I know have worked in other regions. That's why I try to get all of the peers in the state together once a month so that they can share best practices. And I really want them to network without me. You know, I'm not so precious that I think I'm essential to this mix. I don't know, did that answer your question?
We don't have a response yet, but I will let you know if there's a response or follow up on that question.
I'm happy to try and come at it a different direction.
And this one might shed some light as well. There's someone asking, I'm curious about the specific roles of peers and harm reduction teams.
Okay. Again, that is kind of a case by case. So when you're out, say you're out in the community of an evening, meeting with the people you fairly regularly see, and you may be saying, hey, great news, we've got some Hep C and HIV testing that's available if you're interested in checking on your status, or maybe getting some treatment or whatever. And oh, by the way, this is John or whoever. And so it's a gradual relationship building, because they're not the people they're used to encountering sometimes. So they don't have I don't have a specific job description for them. I have a role in mind for them, which is to be available and talk about, maybe if it's appropriate, what recovery looked like for me, or maybe just, hey, let's see if we can get you some transport options. Why don't you come drop in at the office on Tuesday, or when are you free? And that's kind of how it's working out. So that, like I said, we have both static and mobile incarnations of these harm reduction teams. They have both at all times. So that's kind of how that rolls out. It's not this is brand new. So we're it started in January last year, and it's been shut down a lot of the time. So we're really only opening up a lot this year. So a lot of the harm reduction stuff has kind of only just gotten back off the ground in the last few months.
Thank you for answering that one. I hope that helped with the other one as well. We also have a question here, and there's not a lot of details. So if this is your question and I go at it wrong, please make sure to put it in the Q&A box again. But this one is asking about assessments and screening for placements.
So we use SBIRD a lot. Screening, brief intervention, referral. And all of our peers are places where there are also people with licensure. So they can always refer up to their supervisor. But a lot of what happens is we have a bunch of forms designed to help them not screen in a clinical sense, but get a good grip on, this person's interested in treatment. They indicate that they have these needs. I'd like to refer them to this person, or just run over and talk to your clinician and go, hey, I got a guy who's really interested in going inpatient. Do you have time to talk to him today? A lot of it is real, like face-to-face let's have a chat about this. But we do have documentation that says, yep, talk to this individual. You know, this was the outcome, referred them to so-and-so, so that we can track that data to see. Kind of fascinating. A lot of the peers at the LGEs for STR, it worked out at 5.9 encounters prior to any kind of referral, whether that was to a mental health professional or medical doctor or treatment option. So, you know, I try to impress on them that this is not necessarily, you know, it's going to be unusual that someone's going to come in and sit down and go, hey, great, sign me up, send me to treatment. It's that relationship building that's gonna do the trick. So don't get frustrated if you've talked to somebody for 6 weeks and nothing's happened, because something is often happening in the background and you're not aware of it yet, but it's gonna bear fruit if you stick with it.
That's definitely something that I love to hear about as well. I have another follow-up for that. In how would you describe the difference between the peer-based assessments that you say are not clinical and the clinical assessments?
Well, a clinical assessment is going to be way more detailed. You know, peers are not clinicians. So, but I mean, I always loved the phrase practicing alcoholic because it cracked me up. I was not practicing. I was a full-blown professional. And I was also a professional drug user. So I didn't need any help practicing. And yeah, no offense, but it takes one to know one. Not necessarily. A lot of people can spot one. If I'm talking to somebody and I listen to the way they're describing their usage patterns and all the rest of it, I'm going to take your word for it that this is how you're using. And it's pretty, you know, they'll make it pretty clear once they're comfortable with you that their usage is starting to become a problem for them. And so our assessment questions are, you know, do you have an opioid use diagnosis? Do you have, you know, they're real standard questions, but they will help you get to the underlying story. And it's always driven by the person we're serving. You know, I'm not going to say you should go talk to our clinician, but if they are interested in moving further, I'll say, you know what, let's set you up an appointment with the clinician. We can go through all of this, because there's going to be different levels of care indicated based on the individual. And that's not my job to decide, you know, where do you fit in the ASAM levels of care. This is, this is knowing our roles and our boundaries.
Thank you for that. It sounds like with the referrals, peers are doing those a lot. And there's a question that came in asking, are peers serving as the glue between the coordinating agencies?
That's how I want them to be. If you look at treatment as a continuum of care, I want the peer to be between all of them, right? I want them to fit in wherever there's a dialogue needed. You know, something that happens frequently when I'm working with somebody is that they don't know what to say to their therapist or their counselor or whatever. We'll game that out. I'll play the role of their counselor, or I'll play the role of their doctor because they don't like their meds and they want to change them. So I'll game that out with them and see how and they'll go, oh, really? Could I ask that? You betcha. You're a doctor. You're allowed to ask whatever you want. But just giving them permission to be more directly involved. You know, a lot of the time we accept at face value whatever we're told within a kind of medical model. So allowing people to take agency for themselves and giving them permission and skills so that they can do that more effectively and advocate for themselves, that's the role of the peer as far as I can see it. And so they can really help between that and be like, hey, look, the reason they keep missing appointments, they don't have access to transport. We need to figure out a way to get them back and forth. And that can be the difference between somebody really engaging in their own treatment and not being able to.
Thank you so much for explaining that. We have one last question and we have time for one last question. So we are perfect. Besides getting the grants, what state level or organizational supports were most important to get the program started and to get peers hired?
Unfortunately, Louisiana is cash poor. Our state departmental budget really doesn't allow for a whole lot of continuity. And that's a huge frustration. So most of what I've been talking about today is 100% grant funded. And that's something that's got to change, but it can be a really heavy lift convincing the state legislature that these are dollars that need to be spent. Then you really do encounter a lot of the lack of education around what harm reduction means, around what, why are you giving drug users, free drugs? I don't get free cancer treatment. It becomes a really tricky model. So I really wish we had more money for continuity. One big hope is that the Medicare reimbursement for Medicaid reimbursement for peer support specialists is going to make a big difference to us and being able to keep things moving after the grant dollars move away.
Thank you so much for being willing to provide us this information. And if there's any other questions that people have for you, is there a way that they can contact you?
Absolutely. You can stick it in the chat if you want. Brent.ambacher@la.gov.
Thank you again. I really appreciate you sharing all of your knowledge and experience with us. Our next webinar in this series is going to highlight New Mexico, and we are so excited to bring their wisdom here, just as Brent brought his wisdom here for us today. Thank you, everybody, and I'm so grateful. Have a wonderful rest of your day.
Thank you, everybody.